Rosita is my friend. Okay, see, so you see how old I am? Yeah, I've been working in 9 private hospitals. Okay, but now I'm actually the assistant general manager for one of the maternity hospitals in Damansara. So I took care of the whole hospital, which means I take care of the management, operation, and also nursing services. But we are small. We are only 8 bedded and 5 bassinets for babies. Okay? Alright, so I shall put this on that because it is protocol, right? Okay. And of course, today I'll be sharing 2 topics which I think you will be seeing in the home when you care for a client at home, right? So you definitely will find a patient with tracheostomy and also catheter. Am I right? So have you all been to the field yet?
No.
Have you gone to the home, to the house of the client yet? Not yet. So this is like to prepare you. Am I right?
Yes.
So my topic is actually quite heavy. Because, when it comes to dealing with patients or customers, we have to be very serious. Am I right?
Yeah.
But I'll try my best within my capabilities to make it simpler. Okay, don't worry about the wordy slides. Okay, this is actually prepared for some of my nurses back then. Right? Okay, so welcome to Malaysia. I know you've been here for quite some time, right?
Yes.
Some 11 years I asked the other just now, 5 years, 4 years, 9 years. Alright? Alright, so welcome to the nursing community in Malaysia. Right? So, okay, we'll talk about tracheostomy management. So definitely you will be seeing this type of patient or customers, as you can see on the slides. And that is a happy face with tracheostomy. Okay, some patients with tracheostomy they accept their condition. They are positive. That's why you can see the happy face. Some can be very grumpy. Look at that lady. Whenever you want to go and do suctioning, they feel very angry because it causes a lot of discomfort. Unless you explain well and then you do gently. Okay? So at any time, if I go fast, please stop me, yeah? Okay? Okay. Objective today is, at the end of this presentation, all of you will be able to care for a patient with tracheostomy. At least you know what is tracheostomy, alright, and you can perform dressing for tracheostomy, okay, and you can suction, okay, a patient from a tracheostomy port, and you can actually do some inspection around the skin of the stoma, alright. So what is tracheostomy? Did anyone have ever seen someone with tracheostomy? Okay. Where?
With my patient.
Your patient, or you've been dealing with patient, and then you can help me. Actually, she can teach all of you. No. She can share some of that experience. Yeah. Okay. All right. Okay. This is actually a tracheostomy. Most of the time, the tracheostomy is done in operation theatre because the patient needs to go under anesthesia. Then we have to cut open and put a tube for them. Alright, it is actually done at the anterior wall of your trachea. If you know the anatomy, have you all learned anatomy? Yes? Not yet, huh?
I told already.
Sorry? Yes?
I told already about anatomy.
Okay, I think now with self-learning, we can always Google. Right, Google is our best friend now.
Yes.
Anything you want to know, you just Google, everything will come up. But be careful. Some of the information might not be true. Okay, select the real one, the actual, the true one. Yeah? Okay, so we will open up the trachea. just below your vocal cord. Okay, but of course your esophagus is at the back. Okay? So why do we need to put a tracheostomy? Okay, normally it is done for one of these three reasons. Okay, to bypass an obstructed upper airway, meaning that you are bypassing. So you are not breathing from here anymore. Because normally, normal person will breathe through the nose, right? Or your mouth. And you will go down to your lungs, your trachea and your lungs. But because sometimes the patient has got some big tumor obstructing, so we have to cut open just below the tumor. Alright, so that we can breathe. Yeah? And to clean and remove secretions from the airway, sometimes the patient has got a very, the lung is packed with mucus, secretions, phlegms, and you want to remove it. Sometimes it's very difficult to remove from the nose or the mouth, right? So we have to open up and do suction properly so that we clear off the lungs. Okay? And to more easily and usually more safely deliver oxygen to the lungs. Okay, sometimes you can see this, most of the patients with tracheostomy in ICU. Alright? You can see most of them with so many tubes, tracheostomy, they have tubes all over the hand, they have the catheter, they have back tube, they have so many tubes all over. So where it is done, that I mentioned earlier, anterior wall of the trachea and below the larynx. So this is it. Okay, it is actually introduced here. Just below your voice box or your larynx. This is where your food goes in. So we have to be very careful to insert the tracheostomy tube. It's just right in front. The patient with tracheostomy can still eat. They can still eat at normal person. Sometimes you might not know they have tracheostomy because they can just walk like normal person. But definitely they'll be wearing a turtleneck because some people will feel very embarrassed. And when they walk with tracheostomy, people will be staring at their neck, right? So they have to take care of their body image. Okay? So far so good? Yes. You all had lunch? Yeah. You all had rice? Yes. Do you feel sleepy? No. Okay. If you feel sleepy, let me know. I'll get you to do some exercises. Okay? So this is the tracheostomy tube. We have got so many types. We have a cuff one. We have an uncuffed, fenestrated. We have adjustable flange. This is the flange. This is the inner cannula, and this is the silver type. But this is actually not used anymore. This is actually, today, now is the 21st century, we don't use this anymore. Those days. Back in when I was not born yet. Okay? And you also do not know whether you are coming or not to this world, right? But thank God you are here. So this is actually the component for your tracheostomy tube. You have an outer cannula, you have cuff. This is the cuff, but when you inflate with air through this balloon, then it will be inflated. So that it will hold it in your trachea. It does not come out. Okay, so that is the inner cannula and obturator. So care of patient with tracheostomy tube consists of three major components. Stoma care. The opening is called a stoma. Yeah? Alright. So same if you have a patient who actually underwent any... Exactly. That is also a stoma. So when you mention stoma, you have to be very specific. You have to call it as the stoma, or you want to call it as a stoma for tracheostomy. Otherwise people might misunderstood, right? Where is the stoma? The stoma or no stoma, or where's the stoma? Okay, the stoma is just practically an opening. Okay? Alright. Tracheostomy dressing, you have to perform dressing because there will be a lot of secretions all around, especially for the new ones, right? You can see sometimes we do not take care of the tracheostomy, you can have infection, right? So you have to do dressing. And then you have to suction. Because remember, one of the reasons why we have tracheostomy tube is to clear off the secretions from the lung. Okay, so we have to perform suctioning. Do you perform suctioning, ma'am?
Yes, ma'am.
Your name? Anne. You have done suctioning before?
Yes, ma'am.
Good.
But it's only 1 week like that, for reliever only.
Okay, sorry?
Reliever only.
Alright. So we will cover all this, yeah? Okay, this is the stoma that we were talking about just now. Okay, this is the stoma. This is the tract tube. And surrounding here is the stoma. Is the skin around the stoma, and underneath this opening is a stoma. You can see this is like not very healthy because you can see some granulation, some tissue. You know, when you open up a skin, sometimes when it heals, right? The tissue underneath the skin can come up, right? So it forms a granuloma here, right? So you see all this very fresh, but this is not very healthy. A nice tracheostomy stoma should not have granulomas. Probably initially yes, but later on, once it heals, it will shrink and goes in back. Alright, so this is also another tracheostomy. This is the stoma. Okay, this is the skin around it. Okay, so you must always inspect the stoma. Okay, so you must look for the signs of infection. Right, you remember, it's naturally, whenever you open up the skin, the tendency to get infection is high. Am I right? If you get cut, if you don't take care of your cut, what will happen? Infection. Same thing. It doesn't matter where you get cuts. Okay, if you don't take care, you will get infected. Okay, so if you notice that the area tends to be red, this is redness, right? Tender, you see sometimes you feel that something is underneath the skin. Maybe it's pus, right? Some fluids and all that. Okay, or it smells. Whenever there's an infection, it will smell. Okay, not nice smell, right? So you must always call a doctor. Definitely, you have to call a doctor. Because we nurses, we are not doctors. Okay, but we are actually the most important person between the patient and the doctor. Am I right?
Yes.
So don't you think that nurses are important?
Very important.
Very important. So, congratulations, you are also part of the team. Yeah? Alright, then sometimes you can see some greenish, yellowish drainage that comes out from the stoma. That is also a sign of infection. Okay, so being a nurse requires you to be very observant. Okay, the moment you go to the patient, you don't just look at the patient, right? You scan the whole body. Right?
Yes.
You want to see whether is there anything wrong, something else wrong with the patient, not only focusing on the stomach.
Yes.
So that's why when you're looking at the patient with tracheostomy, you have to look everywhere around the area. Okay? So far so good?
Yes.
So dressing has to be done at least once a day and
Twice a day.
good. So is that a new patient, or old patient, or chronic patient? How old was your patient?
Very old already.
Very old. So see when we, it's natural when we become older.
Yeah.
So we are like babies, right? We need more attention, we need more care. Suddenly we cannot care for ourselves. So we are working on someone else to take care of us. Okay? So we cannot do it. So you can do more often, like what Anne said, twice a day. Better. Good. If you see the stoma, you see the tract tube is dirty, you can do twice a day. No issues. Okay? Patient with new tract or ventilators may need tract more often because it's new. So you want to prevent infection, so you might do more often. Okay, maybe less than 7 days, you want to do more often. Okay? So for tracheostomy dressing, there are actually many ways on how people do dressing for tracheostomy. Some use disposable sets. Those who are rich, they will prepare you a disposable set. Some, they prepare you a set which is clean. It can be done. It can be done as long as some part or some components of the set are sterile. Okay? You know what is sterile? What is the meaning of sterile? Sterile is, that means that, yes, it's beyond sanitization. So you kill, say for example, if you put this in the sterilizer, you kill almost 99.9% of germs. It's very, very clean. So you call it sterile. You put in the autoclave. You know what is an autoclave? A big machine where you sterilize and do sterilization and kill all those whatever germs you have on this. Okay, but not every item can go under sterilization. Some can melt. So those who can stand high heat within a room. Is it who said that? High heat? You how long have you been in this? Huh? You Google? What's your name? Salma. Salma. How do you know about that?
Well, it's just because I look after the dementia patient, and every time I make sure that everything else is, I sterilize it the way I look.
Oh, that's what. Good. Good. At least she knows. So now I'm sharing all of you. The meaning we have got two experts here already, Anne and Salma. Okay, they can help me, and they can help you also, right? Because I will not be here tomorrow or the day after. Okay, I will be just for 1 or 2 hours with you, right? Okay, so this is what you need. Okay, for your tracheostomy dressing, you need a specimen cups so that you don't pour water inside there, because when you suck, you want to clear off your suction catheter. Okay, and you need gauze. Okay, tracheostomy dressing to cover the stomach. You cannot just leave it open because it's bare wound, right? So you have to cover, and you need hydrogen peroxide, saline or saline you call it. You need a sterile gloves, right? Because you don't want to introduce any infection to your stomach. Sterile cotton tip applicator or your Q-tips, it has to be sterile because you need to touch the wound, right? So it has to be sterile. Do not use cotton wool because cotton wool has got lint. You know the wool that we use when you clean your, remove your lint cup. Sometimes you see very tiny lint that lives on your skin. That one cannot, because it becomes a foreign body on your stomach. Alright, so when there's a foreign body on your raw wound, it will become infected. Yeah. Zinc or bactricin as ordered. This is ordered by doctors. Some antibiotic cream. Okay, if it is needed, yes. Yeah, not all. But even if you need to apply, you have to apply it very deep, because most of the time it contains steroids. So steroids can cause some scarring, very bad, with thick scar on the skin. So you have to apply very deep. Am I right? And of course, tracheostomy suction supplies and oxygenation lubrication as needed. Your HME filters, if they are connected to a machine to breathe. Some patients with tracheostomy, they need a support, a ventilator support, or an oxygen to help them breathe. Yeah? So pre-procedure, of course, you have to wash your hands. This is very important. I will leave my slides here later so that you can see. It's like additional notes for you. Yeah? Wash your hands. Okay, if you have your sanitizer or alcohol-based hand rub, please do. Okay, and moreover, it's a common, a must thing. It's a must thing to do now, right? So same, if you want to perform a procedure. So make sure patient is lying in a very comfortable position. So you must make sure the patient is comfortable, so that if they are not comfortable, what they will do? What will they do? I mean, if you are a patient, you are a customer, somebody asks you to lie down because I want to do a procedure on you. So how would you want it to be? Whether you want to be comfortable so that she or he can do a procedure, or you just want to be so comfortable, same goes. If you always think for the patient, meaning you have empathy to the patient, you will do well. Okay, so treat the patient like how you yourself want it to be. That is what I always keep in my mind. Or you want your parents, right? How you want a nurse or whoever you want to treat your parents or your siblings, your sisters. That's how you treat people. Okay, it's like that, huh? And then make sure they lie down comfortably so that you can perform and they can cooperate with you. Open the cotton tips, track gauze and regular gauze. And then you have to make sure if they have track ties, because the tracheostomy is just a tube inserted inside the trachea. It has got a flange, just now when I mentioned. Okay, you need a tie to hold. Otherwise the track tube can dislodge. when they cough, right? So a force, positive force, and then the thread can come out. So you need to see whether your patient has got a tie or not. If yes, you have to prepare that nicely. So that not in the middle of doing dressing, then with sterile glove, you have to cut. Once you are sterile, you cannot touch the sterile areas. Is that right? Right. So I always mention N and someone. Unless someone else says something, I will also put it in there. Okay? This is good, it doesn't matter. We are learning. I'm sharing. Okay? I'm not teaching, I'm guiding you, I'm sharing what I have, the knowledge that I have. Yeah? Okay, and then pour half-strength hydrogen peroxide into 1 cup, because we have 2 cups earlier, right? And then stir water into the other cup. Because you have to dilute. You cannot use neat hydrogen peroxide. Hydrogen peroxide is very corrosive. Alright? So you have to dilute it. You can also use saline if you want to. Depends on the doctor's prescription. Okay, they will assess the skin of the patient, whether it's a new tracheostomy or old tracheostomy. From there, the doctors will know what to prescribe. So we follow. Intra-procedure means during procedure. Okay, again, once you have already touched your patient, prepare your patient, put them on a comfortable position. Prior to doing the procedure, you still have to wash your hands, right? Because you want to touch all the sterile dressing sets and all that. Yeah, make sure. Put on a sterile glove, and then you start cleaning the area. So how do you clean? I think, have you learned wound management today? Yeah. So how is it going to be? How many types of wound you have? Anyone? 3, 4, 5, 6. Whether it's dirty, whether it's a clean wound. So how's the motion like? Whether you clean from outside to in or in to out? So this is considered as a clean wound, right? Yeah? Okay, you cannot be cleaning from outside to inside because you're bringing all the germs into the stomach. It has to be inside and out. Okay. Is that right? Please. If you need to go, just go. Fine. We are adult here. I'm treating everyone as adult. Okay? Alright, so normally if a chronic patient, you don't use hydrogen peroxide all the time. What solution do you use for your patient, Asta?
Only water.
Exactly. Water is actually the best. Even the best dermatologist in Malaysia once advised, the best facial cleanser or whatever you use to wash your face is just water. Yeah? So soap and water is okay. Okay, but make sure the soap is mild, not the strong one. Mild for babies. Look at your patient, whether they are old, they are young, or they are small children. So how you choose which one to use. Okay? Alright, and using, like what I said, using hydrogen peroxide only to remove encrusted solutions. Let's say, for example, around the stoma you have got, or around the flange you have got so many mucus. When it dries up, it becomes so hard, right? So you can always remove the encrusted mucus with hydrogen peroxide. Because you know, by nature, hydrogen peroxide, when you pour, it will bubble up like how you pour on your hand, right? I think those days, when I was in secondary school, at that time we didn't earn any money, right? So we asked from our parents. So I want to make my hair blonde. I use hydrogen peroxide. Has anybody used that before? No. So you all use hair dye, yeah? Because you're all still young. I'm old already. Okay? It was back in the 90s. Okay, so once you put it on your hair, it becomes blonde. Seriously. You can try it.
Also in your wound it's also made from.
Yeah, but only onto encrusted area because you want to remove that encrusted mucus. Yeah? Okay? Okay, so be careful when you are dealing with children. Huh? So rinse the area. Rinse means you just dab the area. Okay, with your Q-tip. Make sure that your Q-tip is soaked in dry water. It has to be a little bit damp. Not too wet, not too dry. Okay, and then you have to pat dry the gauze pad and dry cotton tips. Make sure it's dry before you change your dressing. And before you put a dressing, it has to be dry, the area. Okay, if you need to put the antibiotic cream, please do. Okay, your patient has an exposed tracheostomy, or you have a dressing underneath.
Just only simple dressing, and then after cover with the gauze, and then return back the cannula or something like that, and tie it from here.
Yeah, yeah, very simple one, right? Because your patient is quite old, and it has got a chronic tracheostomy already. I'm sure they are all dried out, right? So, but on and off, you just make sure that it is actually slightly moist, not too moist, not too dry. Because dry skin can cause itchiness, right? So those who can move their hands can feel scratch. Alright, okay? So I think it's just a keyhole dressing. Unless your client is very super duper rich, they have a pre-cut sterile dressing, please just use whatever that you want. Okay? So it's all by their request. And what has been prepared for us. Okay? Are you okay? It's okay? You need some exercise? Okay? Alright, so you must, when you put your tie, you have to tie so that it does not come out, right? Stabilize it. So make sure that it's not too tight, okay? So how do you check whether it's not one finger, slide inside, like this. So that's why I put slide one finger underneath to check whether it's loose or tight. Okay, but for a new tracheostomy, definitely it will swell up. Same thing when we get cut. The moment we can see some bump, right? So that is a mechanism whenever you cut the skin. Alright? So you must make sure that's why you must know your patient, whether it's a new tracheostomy or how many days will it be, so that you can plan your nursing care. So you must know. Whenever you have a client, you must get at least a report, right? So that you can plan. Otherwise you can't. Okay, so if the tracheostomy tube has got a cuff means that we have to inflate from outside the balloon, right? So that the air will go into the cuff, and then it will actually hold the tip of your tracheostomy inside your trachea. Make sure that it is not too much air or less, because less it can come out. If it is if the balloon is too overflown balloon, it will suppress the trachea wall, which is also not good. So normally on a tracheostomy, there will be an instruction on how much air you need to inflate. Follow that exactly. Don't over or under. Just nice follow the instruction. Because it can be varies. It's not all the same. Depending on the size. Because the size maybe you definitely need a bigger balloon, right? Okay? So of course you have to monitor the skin, check for the sign of infection, any granulomas, any pus there, any bad smell. When you do dressing, you must see all this. And if there is, please report. Definitely you have to document somewhere, right? As your nursing documentation, which is very important. Okay? Alright, check with the doctor before applying any ointment near the tract, like I said earlier, the antibiotic cream. Check. If it is prescribed, then you have to go. But would it vary? Light. Not too much. So after the procedure, make sure you remove the glove, discard all the equipment. Then make sure that you put your patient back into a comfortable position. Normally, how does a patient with a tracheostomy sit or lie down? What do you think the best position for them?
Supine.
Supine? Slightly raised? Maybe? 30 degrees?
35. Or 240.
Slightly in a semi-foulers. You have learned positioning?
Not yet.
Oh, okay. It's a foulers. Foulers is a sitting position. But if it is a semi, it's about 45 degrees. You can raise a bit like 30 degrees so that they feel more comfortable. Yeah. And you know that tracheostomy patient has got a lot of fluid sometimes in their lungs. So in order to help them to have a good expansion of their lungs, they have to sit slightly. Am I right? Okay, if you have a cough, how would you like to sit, to lie down? Slightly higher? Same thing. Same thing. If you lie flat, you feel so congested, right? Sometimes you would prefer to sit and sleep rather than to sit down. Alright, same thing. Okay, the condition is the same. Okay? Offer oral hygiene because it can be dry for chronic patient bedridden for so many years, they cannot help themselves. So you do some oral care. You learn about oral care, you help them to moisten and clean their teeth and their mouth, the inner side of the mouth. Alright, so that it will not be so dry. Okay, remember our tracheostomy patients, some of them can eat because they are two different anatomy, right? Trachea is in front, esophagus is at the back. But they have to eat slowly lah. But some chronic patient, maybe an ANS patient has got a tube, or he or she can eat. She can sit.
They can stand.
Exactly. Cannot have big chunk of chicken. Alright, because you see chronic patients, they have limitation in chewing, right? So they have to eat bland food or soft diet and things like that. Okay, so there are times when you have to change the inner cannula if it is needed only. Okay, so you gather your supplies. Okay, you need another cannula, you need a glove. You also need a struggle. Remember, you are going into a sterile area, right? Alright, you don't want to introduce any infection. Okay, and then before the procedure, as usual, I mean, if you've been with the patient for so long, they know you very well, fine. But it's a courtesy to explain. Man, uncle, whoever, if you're familiar, if you're close, you call uncle or auntie whatsoever, or if you want to be professional, you can call them by Mr. Madam. I want to change your inner cannula so that they know. They acknowledge that you are helping them out. So they will cooperate with you better. Rather than just go, you never say any good morning, go after you just open up. You like people to do that to you? No, right? So don't do that. That's what I always do. Okay? Put yourself in the person's shoe. Yeah? Okay. Okay, this is how you dispose. Okay, don glove, remove the old one, the inner cannula. Because it has got two cannula if you see the component. Yeah? And then you discard glove and cannula together, put a sterile glove, insert a new one. Because the old one is already old, you just hold and tick and remove. Right? And then quickly remove your glove and then put on your sterile glove, put the new one, because the new one is sterile. Okay? Can you imagine? Can I? After this, go and look for Mr. Google. No, I do that sometimes. Because you do not know everything, right? Yeah. You want to know, you watch YouTube, alright? Yeah. You watch TikTok, now very famous, alright? Who loves TikTok? You love TikTok? You always do. Good. There's so many, even doctors go on TikTok nowadays. Right? Yeah. It's a fun thing. Sometimes you need fun to teach. You cannot be so serious, right? So boring, isn't it? Yeah. So you need some fun to teach. Okay. I said you also must not put to suck patient while you want to remove the secretions. There's so many secretions in the lungs, so you have to remove to maintain their airway. So they have a clear airway. But definitely you have to use your sterile technique. Remember we talked about sterile techniques, huh? It's very important. Okay, so you also want to improve oxygenation and improve the work of breathing for the patient. That's why you want to clear off the path. So they have a clear path to breathe. Yeah? And of course you want to prevent aspiration of food, blood and gastric fluid and prevent infection, because too much fluid in the lung, what will happen? Have you heard pneumonia? Right, for bedridden patients who cannot move, so we have to turn them, correct? Turn 4 hourly, do percussion, that is preventative. Okay, so you want to remove all those secretions, prevent infection, and minimize the risk of them getting atelectasis. Atelectasis is when your lung collapse. Even worse, patient can die. Okay? Because if your fluid is too much, your lung so packed, you cannot expand, right? So it will just collapse. So very important to suck the patient. Okay, sometimes you want to suck because you want to send the fluid or the secretion for lab test. You want to see whether what type of microorganism so that we can give antibiotics to patients. Okay? You can do the suctioning at any time when it's necessary. Don't sit it every 2 hours. What will happen? You can even introduce more infection. Because the more you touch, the more you can introduce infection, right? So do it when it's necessary. Okay? Or even after your chest percussion, when a physiotherapist maybe come to the client's house to do physiotherapist. So when they do percussion, more fluid will be dislodged from the lung wall, and then you can suck. Or before and after sleep, because you want to ensure that your client has got a good sleep. They can breathe better. Okay? So when I mentioned the inexhalator, this is actually sometimes we want to encourage patient to cough. So we will connect this to the patient and then forcing the positive air inside the patient so that they can help to cough. Okay, so when you start the patient, you must be very gentle. Remember, you're going straight to the lung, right? So I will show you. So you need all this to do suctioning. Of course, you need a suction catheter. You need a suction machine. Okay? You need a connecting tubing to connect from a machine to your catheter so that you can suck. Okay? And then you need a catheter which is sterile again, because you're introducing into the patient's stoma with the trachea. And you need one non-sterile glove and one clean glove. One non-sterile glove is actually to touch the machine. The machine is not sterile, it's a clean machine. Right? So, your other glove, sterile glove, is touching the catheter who's going directly into the patient's trachea. Is that how we do? Eh?
Sometimes I'm using 2 gloves.
Yes. Good. Distilled water, you want to rinse off your suction catheter. When you start, there will be some mucus plug inside the lumen of the catheter, right? You want to rinse it off. And you need a clean small paper cup and clean basin. Okay, of course you have to again position the patient. Like I said, how we do dressing, you have to position them in the Fowler's position. Okay, a sitting position or a semi-Fowler. Sitting position better because your track will become a bit straighter. It will become straight. Rather when you lie down, it will suppress and you will actually narrow down your arm. Okay, and then wash your hands. Very important. Hand washing is a must. Before, after, whatever, in between procedure, in between whatever that you do, you need to wash your hands. Okay, this is what we do now. Okay, alright. Then make sure that you check the cuff, whether it's properly inflated or not. Remember, we don't want to be over or under inflated. If it is over, it would press on the tracheal wall. If it is under inflation, the tube can. Okay, this is how you do. Okay, you open the suction catheter package. Okay, and then you pick up the hard plastic end. This is actually, I would love to do it in a practical way because you can see. Unfortunately, this is today I'm just sharing the theories. Okay, I don't have all those catheters with me. Otherwise, I can show you. Okay, probably when we have a chance, we will have a practical session. You will understand better.
Yeah.
Because this is all about having a theory and having to do it. You're going to learn. Anatomy you have to learn. No choice. You cannot learn anatomy by opening a person and see, unless you work in the forensic department. Right? Okay? So, with the supplies that you have, you must know which one is sterile, which one is going into the patient's trachea, it has to be sterile. Which one is touching non-sterile equipment should be non-sterile. You have to differentiate that. So it needs a little bit of technique, but you have to practice. If you don't practice, you'll be a little bit awkward when you hold all this. Okay? Alright, so whenever you finish with when you suck the patient or your client, you must not put so high pressure on your suction machine. Because on your suction machine, there's a pressure valve. Am I right? And so you must make sure it does not go more than 120 millimeter mercury. What will happen? You might accidentally suck whatever that is along the track. The whole lump will come out. Yeah? And do not over push your catheter also. Right? But please remember, it's going straight to the trachea. Okay, so this is a sterile glove or non-sterile? It has to be sterile, right? Because it is touching the catheter. Okay, so make sure that you know how to differentiate. And the tip of, say for example,
Cannula.
oh, can I use it? This one belongs to me. Can I use this, sir? Oh, this is a suction machine.
Suction machine.
Boy, okay, this is good. Okay, you can see all this, right? Reading the valve not more than 120. So you know all the parts in this suction machine. You learn already? Huh? Not yet. Oh, after me, is it? After this? Yeah?
Yes.
Oh, okay, sorry. Okay, so definitely this is the suction catheter. So it cannot be too small or too big. It has to go along with your tracheostomy tube size. Okay, normally 1/2 size smaller will do. Alright, so this size is supposed to be sterile or non-sterile? This sterile or non-sterile? This one? This is the one that you are going to push. So this one has to be sterile. Is this suction tubing sterile? Is this connecting tubing sterile?
Yes.
Are you sure? How you maintain sterile? Because it is actually connecting straight. From here onward, it is sterile because you can pull. But your sterile one cannot touch here. So that's why you can only manage your machines and your suction connecting tubing with your unsterile glove, non-sterile glove. But this is going directly. When you go in, this is sterile, right? So you have to push in. You cannot apply pressure because you're going in. There's nothing to suck when you go in. You're only sucking what is about to come out. Alright? That is the nature, right?
Yeah.
You suck when it's in already. Right? When you are going in, don't apply any pressure. But when you put into the stoma, okay, when you want to put a suction catheter, you can apply intermittent suction. Because just in case if you're pulling out your catheter, it is actually sucking the wall of the trachea, so it's not a continuous sucking. Okay? So if you accidentally suck and then if you put intermittent suction, it will release. Okay, so you have to be very gentle when you suck. Is that how we do? Okay. So because she has experienced it. So that's why I said you have to do a theory when you know. In nursing school, we learn like that, right? That was 25 years ago. Because I went into the management quite long. So I don't have a chance anymore to practice real nursing on patients. But I love talking to patients. Okay? So, you get it? Alright? Okay, this is already very wordy. But like I mentioned just now, this is how you do when you put in your suction catheter, you don't apply any suction. Once you go out, you have to make sure that you go out by a circular motion. Okay, and you can apply intermittent suctions. Okay, once, but you cannot keep on sucking non-stop.
Only 3 minutes.
Yes, you must give chance to the lung to expand. Get the oxygen a bit to the patient, cannot keep on. If you keep on suctioning the patient, what will happen to the patient? Suddenly they become blue. Because when you suck, you are also sucking out the air, no? The oxygen, right? So you must, in between you must leave a space. How long?
3 minutes.
Okay, 3 minutes. In between, stop for a while like that. Remember, they still breathe, but you use the tracheostomy. Okay? 20 to 30 seconds to rest in between suction passes. Give them chance. Okay? Then we apply another suction. Okay, so until you hear no more, like crack, sometimes you can hear, right? When you are having cough, too much phlegm, you can hear. Or you can auscultate using your stethoscope. Yes. Okay, so once you are finished, make sure that you remove everything, your glove, together with the suction tubing catheter, and straight away contain them in the glove. Yeah, and then make sure that you take care of your patient, put them in the comfortable position. Because you must always make sure that they are comfortable, because they can be tired after the suction procedure. Correct? Huh? Yes. So ensure your suctioning tubing also must be changed. You must take care of your equipment also. And documents your outcomes. How much did you suck? What's the finding of the mucus, the secretion, whether it's got blood, whether it's taste, whether it's green, whether it's yellow, whatever findings. Okay? Alright.